So we have a really great speaker this morning. Dr. Toby Campbell is a thoracic oncologist and the chief of palliative care and the Palliative Medicine Fellowship Director still? Now associate, okay, at the University of Wisconsin. Dr. Campbell did his undergraduate and medical school work at University of Virginia, and he did internal medicine residency here at UW and did a palliative medicine fellowship at Northwestern University. His clinical practice is in palliative care and thoracic oncology, and his research interests, as you're going to see, are in communication, education, empathy, high-risk shared decision-making, and models of care for palliative care implementation. Toby has been incredibly successful here at UW. He's published in JAMA Surgery, Annals of Surgery, Intensive Care Medicine, among others. He won the prestigious Sojourns Scholar Leadership Award from the Cambia Foundation in 2014, as well as Young Investigator Awards from ASCO and the International Association for the Study of Lung Cancer. He's been listed among America's Best Doctors in 2015 and 2016. And Toby has been a good friend to many of us in the GYN Oncology Division, helping with a lot of our quality of life research, as well as helping take care of our patients. So please welcome Toby Campbell.
Thank you. You said it was going to be loud, Chris, but it was startlingly loud. I feel like I need to talk quieter. And he said it would reverb if I get too close to that speaker. So we move over here. Good morning. Go ahead. Nice. Ooh, nice. That's going to help. Double amplification, not necessary. I got here at about 7:30 because my kid gets on the bus at 7:07 and I didn't know what else to do, so I just came here. And I reworked my intro in the lobby. And I'm going to try it. So thank you for your patience for the first time with this intro. And I also want to thank the new president of UVA, James Ryan, most recently the dean of the School of Graduate Education at Harvard, for inspiration. So the theme of the talk today is going to be about getting curious. This curiosity is a technique to help you cultivate and grow your capacity for empathy, your ability to connect with other people, to form relationships. It works at work. It works with friends. It works at home. It works really in all aspects in which you're engaging with another human life form. It might work with animals too. I'm not an expert in that. I want you to think about developing the art of asking really good questions. We live in a world of answers. People come to you for answers, and often we provide them quickly, with as best information as we know and as we have at our fingertips. But we live in a world also of answers, and not enough people who ask good questions to really seek to understand where someone is coming from. Because the answer often depends on where you're trying to go. So when I just understand one piece of information, a diagnosis, let's say, and I come up with an answer for that diagnosis, that might not be the right answer for that person. Good questions are a lot harder than they seem. A good question gets past that first easy answer. What would your mom want? Mom would want to live. It gets past that first easy answer because you drill down to the painful, the awful, the difficult, the mysterious, the awe-inspiring. You and your patients' lives will be richer for asking really good questions. In research, Einstein famously once said that if he had an hour to solve a problem, he would spend the first 55 minutes first determining the proper question. In life, think about your good friends. What characterizes a good friend? I would say they're the people who ask really good questions that make you think, that demand you to explore, to analyze, to come to a better understanding of yourself. And through that, you forge a deeper relationship. Okay, that was what I worked on. And now I'll get to the talk. So there's lots of different kinds of high-stakes communication, and so this is just sort of a partial list of things that I came up with in my office on Tuesday of different kinds of tough conversations. But what I want you to have in your mind is that communication is a skill, much like you're learning surgery and different surgical techniques. You can apply those same principles to communication. It's a skill. If I watch someone talk with a patient, I can tell pretty quickly the difference between a beginner and an intermediate and an advanced communicator, just like you can stand at the bottom of a hill and tell the difference between a beginner, an intermediate, and an advanced skier or sailor or chef. Communication is much the same. And it turns out that as you improve your skills, you become more effective, better, more efficient. Time gets shorter because you're more efficient with it. Many people worry that when they work on their communication skills, all it's going to do is slow them down. Imagine the difference between me fixing a dripping faucet and a master plumber fixing a dripping faucet, right? Who's going to take longer? Clearly not him or her. So here are the objectives. Steve said, Toby, you should talk about like a how to do it kind of a talk. So I'm going to do breaking bad news, which you all do a lot. But after hearing a couple of the M&M cases, I think a talk about high-risk shared decision-making and how we engage people around really tough decisions is also going to be a timely topic for you all. We might get to some important words to think about, like want versus think, say, and tell. And a question which I really like that emerged from our research, would you like to talk about what this means? And then if we have time, I might introduce two of the new communication tools that I'm studying. One I'm calling Trial Talk, which I can't talk about in great detail because it's currently a randomized controlled trial, and 3 of you are in the study. Thank you. And so those in the control group can't learn about the tool, so I have to be careful. I'm going to skip over this part because this is like my intro replaced this. So breaking bad news. You know, this shows up in a lot of different ways, right? It could be obvious. An ultrasound confirms that someone's baby has died. It could be much less obvious. You're delivering news about a new diagnosis of diabetes that someone seems to be taking much more harder than you had imagined. So you have your antenna up for where bad news might occur. Spikes is an approach to breaking bad news developed originally by Walter Bale and Bob Buckman, and it involves a few steps. The first is setting the scene. The way to think about this is if you're going to break bad news or you find yourself breaking bad news, set it up so that you do it right and do it once. Often I see people delivering serious news, you know, in a hallway or some other place, maybe a family member that really needs to be there isn't there, and you end up doing it again. Talk about not spending time effectively. Try doing the same conversation twice. So you want to introduce yourself. My name's Toby Campbell. I'm the attending oncologist. You want to acknowledge everyone in the room. You want to sit whenever possible. There's evidence that demonstrates that when you change an experimental variable of whether the doctor sits or stands, people perceive you to be in the room longer when you sit, even when you aren't. It's not billable time, though. I see the light bulbs going off. But there's this perception of connection that changes the perception of how long you're in the room. In the clinic, if you can make a connection with the person first and then the computer, I usually use 2 questions. Your opening question and a follow-up question in which I'm just very focused. And then you can turn to the computer. I'm going to check your labs. I'm going to whatever I need to do. The P in spikes is really the pivotal piece. And these are where you bring up your good questions. How can you guide someone to this new understanding? Because you know bad news is coming. They probably don't know yet. But how can you guide someone to an accurate understanding of their situation when you don't know where they're starting from? So I spend a fair amount of time here understanding where they are. And then I move from there. Sometimes you learn, someone says, I think that I have cancer and that time is pretty short. And if that's true, all of a sudden you're in a position to just say, yeah. And no amount of talking that you would have done would have gotten more clarity. So understanding their perception with questions, well, first in your mindset, you want to understand where they're coming from, because then you can guide. And I'm what people like Steve call a nerd. And so I think in nerd terms, and so I'm thinking of myself as testing hypotheses. My hypothesis is that usually that they don't understand their illness correctly. And I ask questions to test my hypothesis and prove myself right or wrong. Often I open with a disclaimer, like, I just want to make sure we're on the same page. Or so much has happened while you've been in the hospital. Help me understand what you've been able to make sense of. So it doesn't sound like you're quizzing people. The I in spikes is an invitation. This often sounds like, is now an okay time to talk? People will tell you, my husband is going to be here in 10 minutes. He's parking the car. He's in the bathroom doing God knows what. They'll tell you, and then you can say, oh, well, let's just wait for a few minutes, or I'll come back. And then we'll talk more in detail about, would you like to talk about what this means? But this question is a very helpful question. Whenever you've delivered or thinking about delivering some kind of data, maybe it's about a scan or a lab result, and the results come out, and then you say, would you like to talk about what this means? This question frees up both, once the patient has given you permission, this frees up doctors to actually talk really openly. And in our research, this question can be quite magical. The second part of the invitation is a warning shot. This often sounds like, it's not the news we were hoping for, or I have bad news. I use boxing gloves because bad news is bad. And in truth, no amount of softening up the news makes it good. So I'm of the belief that if we're going to be talking about this, let's talk about it in a straightforward and honest way. And then let me run around and catch you afterwards. That's really the empathy piece. The K in spikes is break the news. I've got a stopwatch here because I shoot for a sentence myself. Can I encapsulate the news clearly and concisely? Can I do it in a sentence? Something like, well, let's do some OB ones, right? So, we have the ultrasound results, and I have terrible news. Your baby has died. Now, I never have that conversation, so that might not be quite the right words, but Joel has tried to teach me, and it's something like that. But you guys can, what would you say, Joel, in that situation? That's what you would say. I mean, I don't want your life, but that's how you get to where you need to be, which is a place of understanding, because that's the reality, and so that helps you get there. What happens next is that you're quiet. I sort of think of it like this slide, when it translated from the Mac to the thing didn't work. Jean Grey's not supposed to come up till after I click the button. But what happens is I think of you as like an inner superhero. There's all kinds of information that you know, right? I want to do this test, or I want to refer you to this doctor, or there's all kinds of stuff. And think about how quickly you want to talk about all of that. You've just delivered some life-altering news to someone, and you're ready to tell them about how you're going to take care of them and what's going to happen next. But the first step is to fill up with your inner superhero and hold all of that back. Sometimes people think silence is a mistake, that it suggests you don't know what to say. think about how hard it is to be quiet. And I think you will realize that silence is not a mistake. Silence is not something you are not doing. It is an incredibly active process that's quite difficult. And I would challenge you to build some silence in there and then grow your comfort level with silence and get bigger and bigger, you know? I don't know what other telepaths in this movie are, but maybe we should start with like a mini telepath and then get all the way to Jean Grey. But you can grow that. You can become more comfortable with that. And then they're going to say something or not. Then maybe they start crying. Maybe they get mad. Maybe they ask questions. And here's where you're going to respond with empathic statements. Things like, I can see that you're so sad. It sounds kind of corny here in a conference room, but in the room with someone who's sad, when you just say, I can see, and then tell them what you see, it works. Or praise statements. You know, you're such a hard worker. You've done everything we've asked. It's so clear to me that you love your mother. The longer relationship you have, often the more you have that you can draw upon to praise, but even in short relationships, you can often find something. Exploring statements like, tell me more about something you're seeing. And I also really like I wish statements. I wish I had different news. This helps when someone says things like, there must be something you can do, or there must be something more. You really want to align with them, right? You really want to say, yeah, there is. But here's where you can say, I wish that I could change this. Because you do. The final S in spikes is to summarize and strategize. This is where you let in all the water, right? I'm going to do this and that and refer and etc. This part you know well. So that's spikes and nurse. That's in a really quick time breaking bad news and responding to emotion. Let me tell you that I don't have a false pretense that after hearing me talk about it for 10 minutes, you'll be able to walk into a room and easily go through spikes and nurse. Much like physical skills, they require practice. And so there are different opportunities for you to practice these sorts of things. We run communication workshops with actors where you get lots of intensive opportunities to practice. But you can do it in little ways in your own life with your colleagues or an attending, and you say, hey, we have to go and break some bad news. And the bow tie guy, I've forgotten his name now, talked about spikes and nurse. And I looked it up, and I'm going to try to understand their perception. And would you give me feedback on the questions that I ask, and if you think that I mapped out their understanding accurately? Or you say, hey, you know what I'm working on now is delivering the bad news in a clear sentence that everybody understands. And would you give me feedback on how I did that? And if you happen to have a palliative care consult on one of your patients, we love to do this. If you came to one of our staff and said, hey, what I'm working on is pulling spikes into a bad news situation, we'll probably pass out. And then after we pick ourselves up, we will say, we would love to watch you do that. Our palliative care team is happy to do what we call coach consults. So they're intended to be one-off consults. You might call and say, I have to go deliver bad news. And it's like a territory, I'm terrified. Or maybe you're a surgeon, so you'll probably say something less like terrified. But you'll say, the point will be, I would like some help. And we would say, we would love to come with you and give you feedback on that. Now I want to transition. So are there questions about breaking bad news? Because after watching Eminem, I think we should talk about big decisions. How do you help people make big decisions, whether or not to have this surgery versus that surgery or not surgery? And so I wanted to turn to that, but I'm happy to talk about bad news if there are questions. Okay, so I designed, and then together with my colleague from vascular surgery, Gretchen Schwarzy, and then a whole host of others, we have studied a tool called best case, worst case. Let me see where I go first. Yeah, we're going to talk about what it is. Okay, good. So best case, worst case actually was originally designed several years ago when I was in my second year or so here, and we had a new stroke attending, Justin Satin, who was running the stroke program. And Justin decided that he really thought there should be a palliative care consult in patients after stroke before the placement of a peg in a trach. And so I found myself, I was on service most of the time because we only had 2 attendings at that time. And I was on service a lot, and I was faced with this really difficult situation in which there was a tremendous amount of outcome uncertainty. I mean, we don't know how much neurologic recovery your loved one's going to have exactly. There's a lot of uncertainty here. And yet people have to make a decision. Do we go peg trach and nursing home placement, or do we allow them to die? So there's tremendous differences between these choices and tremendous uncertainty. And that was the situation that we faced. So how do you counsel a family member in this circumstance? And so this was basically where best case, worst case came from. Although it was certainly influenced by a thoracic surgery colleague of mine who consulted me after she had done an esophagectomy and said, this surgery ran really effing well. And this family wants to withdraw post-op day 2, and it's just ridiculous. And now I have to deal with an ethics consult, and, can you help? And so I wanted to also try to get to a space where if we've gone down a path of a major surgery, we are all certain that this was the path we are on. That you're not going to have a post-op day 2, family walks in and says, Mom would have never wanted this. That we can be sure before we got to post-op day 2 that we were all on the same page. Because this you can't fix. The fix is yesterday or the week before when you were in clinic. So a tool is born, and we call it best case, worst case. And it looks like this. I'm going to go through in a little bit more detail, but basically you present that there's 2 options. Now in this example case, we have total colectomy and comfort care, but the 2 options might be different in real life. And so to do this, I am going to, so now Chris, if you want to help me, I don't know where the video is. Because it's probably in a different place, right? Do I hit escape, maybe? There. Okay, and we have to do some hocus pocus here because the audio is not working. So what I'm going to do, I want everybody to buckle in, is I'm going to push play over here and play on my laptop at the same time and get the audio to line up as closely as we can. Let's see what this is. Okay. Hi. This is going to work. Okay, everybody ready? Go. I'm Toby Campbell, a palliative care doctor at the University of Wisconsin. I'm here to teach you how to use best case, worst case, a communication tool developed by our research group to help surgeons discuss difficult treatment decisions with patients and their families. This story starts with your patient, Mr. Lombardi. Mr. Lombardi is an 81-year-old man with fulminant C. difficile colitis. He has a history of morbid obesity, hypertension, diabetes mellitus, stage 3 chronic kidney disease, and COPD on home oxygen. 2 days ago, you started him on a trial of conservative management, but his white blood cell count has continued to rise, his kidneys are failing, and he has peritonitis on exam. Now, you need to talk to his family about his options. First, you must set the stage that this surgical problem is bad news. Patients and families need to understand that this event is unlikely to end well and could potentially result in his death. Even if he does survive, it's improbable he will be just as he was before. How can you be sure Mr. Lombardi's family understands his condition is grave? It is essential to clearly announce that he is very ill. You might say something like, I have some bad news. Your dad has a life-threatening problem. It is going to change his life. I worry he's going to die, even with surgery. I want to make sure you understand the options. Next, introduce the best case, worst case framework. Let's look at the graphic aid. To begin, identify which options you will present. In Mr. Lombardi's case, you're presenting 2 options, total colectomy and a non-surgical option, comfort care. For each option, draw a box and a star connected by a vertical line. The box represents the worst case outcome associated with a given treatment, and the star represents the best case outcome. Somewhere along this line lies the most likely outcome. Most likely may be close to or the same as the best case or worst case, or it could be somewhere in between. The idea is for you to combine your knowledge of the patient's overall health with your understanding of the current problem to give patients and families your best estimate of what is likely to happen. Telling a story is key. This helps patients imagine an unfamiliar experience so they can prepare and make decisions based on what is important to them. While surgeons often focus on providing precise risk calculation, these numbers don't help patients envision what it is actually like to have surgery. So, how can you explain the risks and benefits? By translating the statistics you know into stories. Instead of talking about a 20% risk of renal failure and a 35% risk of stroke, tell a story about what a patient's life might actually look like if these complications occurred. You show the probability of these events by where you position the most likely outcome on the line between best and worst. Pull out key elements from your story and write them on the graphic aid. During a busy day, this seems time-consuming, but it is critical. Patients and families will refer back to this graphic aid in order to deliberate about options after you have left. Let's get back to Mr. Lombardi. If you operate on him and everything goes really well, in your best-case scenario, what would his recovery be like? Would he be able to go home again? Tell the story. If everything goes well, he will have a big operation to remove his colon, and his stool will come out in a bag. Afterwards, he will be critically ill in the ICU for a number of days. He will need a breathing machine, and he won't be able to talk. In the best-case scenario, we would remove the breathing tube a few days after surgery, and he'd stay in the hospital for another week or so before going to a nursing home, where he'll have to work hard to regain his strength. If his luck continues, he may even be able to go home again, but he will be weaker, have a bag for his stool, and need a lot more help. Let's consider the worst-case scenario. For Mr. Lombardi, the worst case is clearly death after prolonged critical care. So in the worst case, he makes it through the surgery, but he returns to the ICU and is very sick. His post-operative course will be rocky. Maybe his kidneys won't recover and he will need dialysis. Maybe he'll be dependent on the ventilator to help him breathe. He will develop complications that he can't overcome. And ultimately, he never wakes up enough to talk, and he dies in the ICU a few weeks after surgery. Patients often imagine the worst-case scenario as dying in the operating room. It's important to explain what the worst case actually looks like, because a prolonged death in the ICU may be much more agonizing. Let's shift our attention to the most likely scenario. To illustrate this, put a mark somewhere along the vertical line to indicate where this outcome is located in relation to the best case and the worst case, which, for Mr. Lombardi, is down here. It's important to acknowledge the patient's baseline health and note that surgery will not help his underlying diabetes, lung disease, or mobility issues. Keeping this in mind, you say to Mr. Lombardi's family, most likely he'll survive surgery, but he will be pretty sick and in the ICU. He will need a breathing tube, especially because of his COPD, but we can get him out of the ICU after a week. He will likely suffer setbacks that will keep him in the hospital for another week or so. Ultimately, I think we can get him to a nursing home, but he will be much weaker and need a lot of nursing care. Surgery will be hard on him, and he was just barely making it before this happened. I don't think he will ever be independent again, and I expect that even with surgery, he may only live a few more months. As physicians, we know that Mr. Lombardi's comorbidities and acute illness predict a nearly 70% one-year mortality. Best case, worst case helps you translate your knowledge of this important statistic. Telling stories about the range of possible outcomes allows patients and families to visualize what might happen in a way that numbers alone cannot. Now repeat these same steps, describing the best case, worst case, and most likely outcomes for option number 2. For Mr. Lombardi, this is comfort care. So you could say, in the best case, your father gets medicines to control his pain. He will die from this. I can't be sure when, but not right away. If we're lucky, there's time for everyone to gather and to say goodbye. I suspect he won't be able to carry on much conversation, but he may be able to respond in his own way, maybe squeeze your hand, and so on for the worst and most likely scenarios. Next, listen to what they say about the outcomes you just described. Ask them, how are you thinking about this? To reinforce this critical point, write at the bottom of the graphic aid, what is important to you now? If Mr. Lombardi's family simply says they want him to have surgery, that is not enough data. You might reply, okay, I'm glad you've come to a conclusion, but help me understand how you made that decision. How are you thinking about this? Access to this thought process is essential. When you know what is important to them, you can be sure that your recommendation is truly aligned with your patient's values and goals. Once you've elicited their preferences, the final step is to make a recommendation. It is not okay to simply present the options and expect your patients to choose. Your job is to match your knowledge about disease and treatment with their knowledge about what is valuable to the patient. Hopefully, after a conversation like the one I just demonstrated, Mr. Lombardi's family is able to tell you what he would think or say about the outcomes you described. Perhaps he fears being hooked up to a machine. Maybe you learn he is fiercely independent or that he never wanted to be on dialysis. Using this information, you could say, I understand that his independence is really important to him, and you've already discussed his feelings about dialysis. I'm worried that even in the best case with surgery, he would still require several months in a nursing home, and most likely, he will die before we can get him home. I think the outcome you're hoping for is not possible with surgery, and based on what I know about him, I recommend comfort care. Let's summarize. Best case, worst case has the following components. Break bad news. Identify 2 clear treatment options. Create a graphic aid that illustrates the range of outcomes and give it to your patient. You haven't done best case, worst case unless you complete this step. Use storytelling to describe the best, worst, and most likely outcomes. Avoid percentages and statistics. Include the patient's other medical problems in your story and how they will be affected by surgery and postoperative care. Describe how this will impact their overall survival and quality of life. Elicit preferences. Write, what is important to you now on the graphic aid, and allow your patient adequate time to respond. Make a recommendation. So, what next? Many people hear about best case, worst case and say, I already do that. I challenge you to go and try it this way. Okay. So one of the reasons why I show the video is that having taught about best case, worst case for a long time, we made the video, and that me is far more time efficient than this me. He gets through it every time in the same amount of time, and I take often a lot longer to do it. To answer the questions that no doubt for some of you are there, no, I'm not drawing. I don't have those skills. Yes, we paid for it. It was a lot. So what's important to recognize, and what I want you to do in your minds, is to pull apart informed consent and decision-making. Doctors tend to use the process and the language of informed consent as a decision-making conversation. You have a problem, I have a treatment. The risks and benefits of that treatment are X, Y, and Z, and A, B, and C. Should we proceed? During this, you probably also say you have alternatives. But generally speaking, we talk about the treatment and the risks and benefits of that treatment, and then the you have another choice is sort of an afterthought almost. And then we ask people to choose. What I would submit is actually that conversation from a human cognition perspective is incredibly ineffective at helping people make a value congruent decision. But when you approach it actually with something more like best case, worst case, now you're having a decision-making conversation. And then you only talk about the informed consent for the choice that they've made, right? So if they've got two choices and they choose surgery, well, yes, you still need to do informed consent from a medical legal perspective, and it's important. But if they've not chosen surgery, we don't need to go through all those risks and benefits of surgery. So pull those two conversations apart in your mind. This is a decision-making model designed by Elwin, who's now at Dartmouth. But he talks about COD, choice talk, option talk, decision talk. And best case, worst case fits in his category called option talk, the space in which you're discussing the options. And then things like making a recommendation and getting feedback on that occur in the place where we're talking about the decisions. We did a study. We've got several papers out now. Our study was in acute care surgery, vascular surgery, trauma surgery, cardiac surgery, thoracic surgery. We had 29 surgeons enrolled, 25 completed training. The way this study worked, it was a pre-post design, so the surgeons prior to training were in their control group essentially. They served as their own controls, and then afterwards they flipped to the intervention. The study ran like this. It was for urgent surgical decisions, not emergent surgical decisions, and for hospitalized patients, not clinic patients. And we followed them up at a couple of points afterwards, 3 and 6 months. We also surveyed the physicians 3 and 6 months later. The patients are fairly well balanced between the two arms. We collected quite a lot of data. The training, I don't need to bore you with, but we had 2 hours of training total. And here what the surgeons said at 3 and 6 months. They said that best case, worst case is easy to use almost universally. Most of them, the vast majority of them feel that it's better than what they used to do. No one really thought that it saved them time. And I think this is especially true early on, and especially true if you're someone who just says, you have a problem, I have a treatment, here are the risks and benefits. So in some ways, we're adding a conversation. And one of the things that I love is most of them are still using best case, worst case, 3 and 6 months later. Patients say things like, I won't read all of these, but let's see. It actually helps me now when I'm with my dad at his doctor's appointments to ask more questions when I'm there. If anything, I kind of think his doctor's office could use something like this. We went to interview people at their homes after they had been discharged, if they were alive. Otherwise, we went and met with their family. They were all able to reproduce the document. We didn't ask them to keep it. They all had it. Think of all the paper people accumulate. This is the reason why we emphasize so much that you haven't done best case, worst case unless you've given them this piece of paper. It's because it's really valuable. The number of times that someone who wasn't even at the meeting shows me the thing on their phone because someone else sent them a picture of it happens all the time. So this becomes actually something that you leave the room, but it enables them to continue to deliberate, to map themselves onto this decision that you've framed. So you create it, you frame it, you leave, they continue to work this out, and they start to layer their preferences onto it. So in some ways, it actually continues your conversation even when you're not there. You can't bill for that either. You guys watch this one. So we showed, the sort of nerdy science stuff. The option scale is a way of gauging patient engagement in the decision-making process. These were strongly statistically higher in the post-intervention group as opposed to the pre. Here are some, some of our qualitative data. So some of the themes that we emerged is that the pattern of conversation changed. Pre-intervention, it's things like the problem is linked to a surgical solution. So there's a blockage. To get that opened up, we need surgery. So the problem is the aortic valve is getting smaller. And in order to take care of this problem, we either take the valve out and put another valve in. But after the intervention, we saw, rather than linking to surgical solution, we saw a choice being presented. I actually think we have a choice to make. And so that's kind of where I want to use this little diagram to kind of help go through the choices. Another categorical thing that we saw was how people described outcomes. Pre-intervention, there's really a focus on risks and benefits. There's a risk of reintubation, probably 7 to 8%. There's a risk of death with esophagectomy. Afterwards, we see this transition to a focus on outcome language. Under the best of circumstances, that would involve being in the hospital for probably a week or maybe 2 weeks. And because of your age and the heart problems, part of that might involve being in the intensive care unit. The final sort of major outcome I'll show you is that it changed the way people deliberated about options. So prior, the justification was based on eligibility for surgery. So we saw this a lot. If you were considered to be eligible for the surgery, then that was the recommendation. If your abdominal exam gets much worse, we're finished. We go to the operating room because now the patient is eligible. But afterwards, we saw more about eliciting preferences and attempts to align. This is what I know about her. She didn't want a lot of these interventions, and we're going to do a maximum amount of these things if we decide to go for surgery. So my general thought is that surgery, etc. Now, I also like to look at things just sort of from the 10,000-foot viewpoint. So I clipped a conversation, cherry-picked, but I clipped a conversation, same doctor, pre-training, post-training, right before the patient says something, right after the patient says something. They just look different. Like when you zoom all the way out and look at the whole transcript on all the pages, like 9 pages laid out, they look so different at that 10,000. There's just much more dialogue, and it's very interesting. So doctors' behavior is hard to change, but in 2 hours, we were able to pretty significantly alter. We didn't make these conversations perfect, but they looked really different. We use, a checklist during our training to see if people achieve how sort of competent, if you will. And so actually after 2 hours of training, most people can get into the 10 to 12 range out of 15, meaning that they're showing that they can do most of the skills, not all of them. But one of the things that's cool about best case, worst case is we observe really marked differences in people who have just had 2 hours of training and are early versus surgeons who've been working with it for several months. And just to highlight some of the things that I noticed that are different, from an early, middle to an advanced case are, they're really myriad, but at the beginning, I don't know if I want to bore you with all this. It's nerdy stuff. People get better at it. It's a skill. When you use it more, you actually look even more elegant with it. We have a few minutes left. Questions about best case, worst case. I have a couple other things that aren't that important, but I would love to talk about this shared decision-making thing if you want. Otherwise, I can go through some of this other stuff. Do you all see how this could work for you? Where do you think? Yes. Dr. Al-Niami.
Well, thank you again for spending time with you. Anybody who spends time with you actually gets better at what she or he will do and actually perceive life a little bit differently. I do have a question which sometimes most of the times I struggle with is when we go through the scenarios of the options with the patient and the best case and the worst case and what will happen, what sometimes I struggle with is what the end result is. Because sometimes the end result is different with the patient's pathology. Patient comes in with cancer, surgery will actually most likely will be of harm. However, they are focusing on survival and progression-free and overall survival. Well, you are talking about surgery and 2-3 weeks in the hospital. They are not focusing on that. They are focusing on something else. And that sometimes brings me to think about what is my end result? What should I focus on? And sometimes I ask them what they want out of life. And that sometimes is difficult because that's putting a lot of pressure on them to define what the end result is. And then you can talk about the end result. And sometimes that's where most of the times the struggle comes in. And I'd like your advice on that.
Yeah. Before I answer that, if you haven't seen Dr. Al-Niami's talk on Ignite Madison, which you can find online, you got to watch it. It's so good, dude. You're so good on that talk. You're so good. There's a couple things that I think are going on. First, in the acute phase when people are reacting emotionally to this new diagnosis of cancer, that takes some space. So first, breaking the bad news and getting them to a place where they're ready to sort of talk cognitively. So that's the first thing that I would say. The second is what you orient towards in terms of the storytelling And if you're sort of interested in decision science, we can talk about this. The language of the sort of science around this is actually called scenario planning. We call it storytelling because that's a more accessible language than scenario planning. But the science behind best case, worst case, for me, is fascinating. But what scenarios you utilize depends on, in many ways, what that patient's hoping for. So you might throw out now that you know all of this, what do you find yourself hoping for? And they say to get cured, to live longer. And so now I'm anchoring my story around, okay, so let's look long term. What are the likelihoods for cure? What are the likelihoods for that long life? Sometimes people say that, and I say, okay, yeah, that makes sense. That's that sort of easy first answer, right? What do you want? I want to live longer. Great. Yeah, I probably could have predicted that. Live longer, why? What do you like? What do you do? What do you hope for? I want to see my kids. I want to finish my book. I want to, there's any number of things that come up. Now you're starting to get into some richness. Okay, so finishing your book is really important. And then you might ask a little bit more about how much time they need, so you're thinking about that. And then you construct it based on their values. So if cure is possible, we're talking about surgery, cure, best case, yeah, you're cured. It's going to be a long road to get there. It's going to be weeks in the hospital. It's going to be months in the nursing home, whatever that looks like. And they're going to go for that because the outcome they're hoping for is possible. And you're going to feel okay with that. But you'll have also presented some sort of non-surgical option or, so the other option is chemotherapy. I put the star way down low because cure is not possible with this option. But in the best case, we help you live a little bit longer and it's not as rough. You don't have weeks and months in the nursing home. And so you juxtapose these two against one another, oriented around, if you can, their sort of guiding star, if that makes sense. Yeah. We are live streaming this baby.
So I think this is super interesting, and I'm sort of trying to think of how I can apply it to my job. So I'm a reproductive endocrinologist, so I do infertility. So I'm not talking about life or death. I'm not talking about OB. We're talking about like IVF and trying to get people pregnant. And so I was just wondering whether you use this for all of your sort of decision making, whether it's just for some of the big stuff, because for IVF, the best case is they get pregnant the first chance, and the worst case is they spend tens of thousands of dollars and never get pregnant. So I just didn't know what sort of difficulty of decisions you apply it to.
I do only use it for what I think of as high-risk decisions. You wouldn't want to spend your time doing this to talk about whether or not to put a Band-Aid on, So that's an extreme, obviously, but somewhere along the line between life and death surgery or trach and peg lies when you would use it. I could see using it in your circumstance because those outcomes are really different. Your patients have probably already given a lot of thought and they have a lot coming in. So, you could use it to say IVF or not IVF. Best case, you have a baby on the first try. Worst case, you never get pregnant. And you could frame that against some alternatives. Really what that's doing is allowing you to get out. They're going home with something that says, I might never get pregnant. And they can reflect back on that if that's actually what happens. So I don't know. Your world's very different than mine. You could play with it and see if it works. I don't pretend that best case, worst case is the solution for every problem. But, the other thing is, Ahmed, in answer to your previous question, is it just came to me as I was talking about that one, but then it already went away again. So let's move on.
Is this on? Okay. I was kind of thinking about, like how would this really apply to OB, because obviously you can't bring this up when someone is needing a crash C-section,
right.
Like for real. But perhaps like one good application that I thought of for, maybe like mode of delivery counseling for someone who's considering like a VBAC or something, if you, best case scenario, for trial of labor, you get a vaginal delivery, worst case, and kind of go through the options there and also the risks of C-section. I think that'd be one widely applicable thing. That's all I have to say.
Great, thank you. It came back to me. So the anchors, the best case and the worst case, think of them as anchors. You're not promising that either of those outcomes is going to occur. It's just the worst that you can imagine might happen, and the best that you can imagine might happen. And then you take into account probabilities in terms of where you place the most likely scenario and how you describe that. So really, from a perspective of pregnancy or surgery or VBAC, for example, after a previous cesarean is, what might happen? How bad could this go? And then where you place that most likely scenario. But that way, they've thought about it. Some people are very risk averse, and they'll look down here and say, gosh, I don't even want to take the chance that might happen. And some people are really oriented around how well this could go, and that's how they make their decision. And other people are really listening to you and your clinical judgment. So what you're doing is just creating those sort of outer bounds so that they have a sense of what's in play and what's not.
So I have a suggestion for your IVF patients, because I often use this for the patients that you guys refer to us with comorbidities. And I find that when I review the best and the worst case scenario, it's really not about the pregnancy. It's about, do you want to have a baby at 23 weeks because, you most likely will get pregnant, right? But then you will have a higher chance of having a baby at 23 weeks and that baby having to need a feeding tube or not able to go to regular school. So I think the most that you can introduce that into the talk, the best I serve your patients when they come, because it's totally nothing that they've never heard before. And I think the other part that I struggle as an MFM is typically end of life, it's one person. I mean, obviously there's a family, but for us, any given day, it's a mother making decisions for a fetus, right? For a fetus life. And then you have a father there. And often they're not on the same page, right? So it's not about, do you want to go to a nursing home? Do you want to write your book? It's about, and a lot of uncertainty, right? Because the question is always, would this kid be able to get on the bus? Right? Because if the kid is able to get on the bus, then a whole bunch of other issues are done. Well, I don't know, okay? I don't know if, the third part of the corpus callosum that is missing is going to be the part that is going to prevent your kid from doing that. And they're very polarized. They're like, if they're not, then I don't want to have this kid. If they are, then I do.
I mean, I just want to say that's a great point, and sounds like, when we talk about surgery and other things, I try to help people recognize really what the worst case looks like. And he's right. It's not getting pregnant. The worst case sounds like that. And then best case, worst case just helps you be honest about the uncertainty and about the unknown. And then what you're doing is you're handing the decision back to the only people who can really make it, with more information and more understanding about what they face, so that they can try to make the decision that's right for them. Well, it's 8 o'clock, Steve. 9 o'clock. I don't know. That says 8, but it's not.
9 o'clock. As always, great talk. Thank you very much, Dr. Campbell.